Hey everybody, thanks for tuning in. In the external version, I wanted to highlight a few things. That the patient has to be term, so 37 weeks or greater before we do this procedure, because there is a small risk that we would need to do an emergency delivery for the baby if it didn't respond well with its heart rate during this procedure. So at its core, the version is what I shared. The provider is trying to rotate the baby from a breech to a vertex presentation. And as the nurse, we have a lot of care that we need to do here. We need to make sure that that tocolytic terbutaline is given before the procedure as it's ordered. And then we also want to make sure that there's been a non-stress test performed that is reactive before we would try to do a procedure that we know may stress the baby out in some way. So showing you again that it's happening. And then the real life version, which I think gives a much better picture of what's occurring during the version. And again, that baby is transverse in this position. So you've got the provider's hands here with the baby's bottom and head up here. And so we wouldn't do this to somebody that we know had twins or low fluid or a placental issue. It clearly wouldn't make sense to do something like this in those circumstances. But it's a great option for a woman who has an uncomplicated pregnancy, has a breech baby, and is really trying to avoid a C-section. Again, it's about a 60% success rate, but each provider, their own success rate is kind of what matters. You want to sort of know which provider in every practice. There's usually one provider that they schedule most of them with because they're the most successful. And again, the risk, the baby could flip back. I have seen that happen with patients, and obviously the other thing is the baby could go into distress during it, which would lead to an emergency cesarean section, in which case they'd be having the same surgery they would have anyway without the procedure. It's just in an emergent fashion, not routine. So we talked about how we're monitoring mom, we're monitoring the baby. So the fetal heart rate will be with a non-stress test both before and after, and we need to have a reactive non-stress test after the procedure, especially before as well, but after especially before we'd feel comfortable discharging that patient. And then we'd have an IV line in. The medication for the tocolytic is given subcutaneously usually, so sub-Q. So why do we have an IV? It's because if we have to go back for an emergency C-section, we want her to have IV access before the procedure. So the other thing is that an internal version usually only happens in a twin delivery. So meaning the first twin is delivered, and when we have twins that are born vaginally, baby A has to be vertexed. Baby B could be in whatever position. But once A is out, we want to try to deliver B in the vertex or head down position. So this is showing a provider trying to rotate that baby in order to get it to deliver. And again, only really in a twin setting. So that brings us to talking about forceps in a vacuum, which I know we mentioned when we talked about characteristics of the fetus, because we talked about what you're seeing over here in this image, right? That caput on the baby, and looking at that. We want to think about that during these procedures, mom is still doing 95% of the work. The provider is really just helping. They're not pulling the baby out. So why do we do these? We use either forceps or a vacuum when mom is just too exhausted to keep pushing, when the baby is in distress, and we know that doing this will get the baby out sometimes 5-10 minutes sooner than if she continued to push on her own, sometimes upward of 15-20 minutes if it's forceps. So with these two procedures, if the head is higher, forceps are used. The head has to be lower in the birth canal in order to successfully use the vacuum. So this is showing you the application of forceps. The provider needs to be really skilled. There's some beautiful forceps deliveries, meaning the provider is well trained in doing them and the procedure goes really well. You want a provider who's really comfortable with forceps and has had many successful forceps birth, but it really can save somebody from a C-section. Typically, we want to see somebody do forceps when that head is at the low position. Mid forceps, right, if that head is at 0 station, that's kind of high up to go in if the baby's head is only at mom's ischial spines. It's kind of hard to do forceps all the way from there. But you are going to make sure that you're explaining what's happening to the parents, that, mom still needs to push as a big intervention, and then the baby's face will have some markings and bruising from the procedure afterwards. So what are you going to do as well when you're thinking about either a vacuum or forceps? Well, you want to make as much room as possible in that woman's pelvis. And if she has an epidural, she's not going to be able to empty her own bladder. So making sure we catheterize her first with a Foley cath to allow as much room as possible so that bladder isn't holding anything up. Knowing where the fetal heart rate is. Now, we spoke today about not ever applying fundal pressure when there's a shoulder dystocia. But in this scenario for a forceps delivery, we don't have a shoulder dystocia. We may put a little pressure fundally, only if a provider asks for it. The mom is most likely going to have an episiotomy and a pretty significant tear. These women are at risk for the 3rd and 4th degree lacerations when they have this. So the vacuum is kind of a misnomer that it really is more of a suction cup when you think about it. So sorry, I know the page is rotating here. So it's really more of a suction cup. You as the nurse are going to be holding this portion here, the pump in your hand. The provider will put this suction cup onto the baby's head, and then what happens is you pump it up when the woman has a contraction. She pushes and the provider pulls at the same time. This is showing you what it looks like in real life. That's what the vacuum is. And again, a big nursing intervention is the patients think you're bringing out a vacuum cleaner. You're not. You're bringing out a suction cup, and you really need to do your best to explain that mom still has to do the majority of the work for sure. She can't give up her efforts of pushing. This is helping. So we talked about how both the forceps and the vacuum lead to a higher risk of a laceration. Often in these cases, because we're putting in instruments, the provider will go ahead and cut an episiotomy before either one of the procedures. If you're cutting an episiotomy, it saves about 5 minutes of time in a woman's pushing. But I don't think that justifies cutting them in a normal context with a fetal heart rate that is, that is in a normal range with a baby that's well oxygenated that we're not worried about. I wouldn't try to save 5 minutes. I've told you I can count on one hand that I've only cut them when I have a baby that's in distress. So this is showing the images of how they can be done. So they can be mediolateral. This is the preferred way because we're going off to the side. We're trying to avoid the anus. Whereas if it's a midline episiotomy, you're more at risk for ending up with 3rd or 4th degree tear and getting rectal involvement. So this is showing you, this is straight from your book, the advantages and disadvantages of the mediolateral to the midline episiotomy. So cesarean births, the video from Baby Center is actually really helpful for this topic, but know that 1/3 of women, as we've talked about, have a cesarean birth, and it's on the Healthy People 2020, it's on all national agendas to decrease our C-section rate. So we know that women who take childbirth education classes, who choose midwifery care, who've exercised through their pregnancy, who've gained the recommended amount of weight, not more than the recommended, that they tend to do better in labor and have less of a risk of a C-section. Walking and squatting in labor, not getting an epidural, those things all help as well to avoid a cesarean delivery. Not being induced is a big one. So this is showing you during a C-section. They have made that low transverse incision on this woman, and the geyser here is the amniotic fluid that breaks when they went in. This is showing you the baby being born. You can get some really beautiful pictures for parents of their baby still being delivered, because that's sort of a missed opportunity that they're not getting to watch. So depending on the setting, you can sometimes end up with these type of pictures. Depends on the hospital policy and the provider whether or not they'd allow a photo of this, but that's the birth of this baby. So here's the reasons for a cesarean delivery. So you have a dystocia, meaning the baby's head and mom's pelvis, and goes into the next one here, just are not a fit. You could have a mom who's got preeclampsia, the PIH, so severely that it's not safe for her to go into labor. If anyone has an active genital herpes lesion, they would be a C-section. If they've had a previous myomectomy, if the baby was in distress, cord prolapse, the baby was breech, or they have another emergent situation, which is the placenta abruption, or we will cover placenta previa, but basically in a placenta previa, you've got your uterus and your cervix down here. So here's your cervix. In this setting of a previa, you've got, like I shared, the placenta is the presenting part, and then you've got the baby up here. So you can't have a vaginal birth if the placenta is the first thing that wants to come out. This is where we would not do a cesarean. We're going to talk about these things when we do the psychosocial cases in class. So if a baby dies in utero, we don't just do a C-section, and that's a lot for parents to process. But it's not in a woman's best interest to do an elective cesarean, or even in the context of a baby that passed away to do cesarean. We need to induce labor in that setting. So like any surgery, it's really clear that there's big risks. I know the first two should not alarm or stand out in any way. You know those. But we're really close to the bladder when we're doing this. So she could end up with bladder injury. Obviously periodic ileus and then complications of anesthesia, but this is much riskier than having a vaginal birth. There's risks to the infant. We talked about that baby has a lot more fluid on board because it didn't come out of the birth canal, so they're more at risk for that transient tachypnea of the newborn. They can get lacerations on their face because as we go in to make the incision on the uterus, that baby could be right up there against the uterine wall and end up with a nick on its face in terms of being cut. The moms, if they're going in for a C-section that has been scheduled and they were never in labor, they get a Spinal, which is basically a dose of medication that will last for a little over an hour, and they don't then need the catheter like you see from an epidural left in their back because they get the injection of medication and they don't get a constant infusion of it. Versus the epidural, if somebody's in labor and has an epidural, we can dose that with more medication when they come back for their C-section if that's something that is needed. The other thing is in a truly emergent C-section, we would do general anesthesia because we don't have time to put in a spinal. So if it's general, you have to realize that no support person can be in the room because the woman's going to be asleep, and we want to get that baby out within 5 minutes of her getting the general. So everything goes really quickly because you don't want that general anesthetic to hit the baby and have an effect on the baby. So there's a lot we do. We need to educate that patient. We need to prep her, so it's a surgical site. So we have razors that we would trim her pubic hair with. That's an important thing to do, again, because it's a surgical site. We do Bicitra to decrease the acids in her stomach before going into the surgery. It tastes kind of chalky, people say. Obviously, she'd need IV access. We'd have monitored the fetal heart. We also, just before we do the skin prep, and we're in the OR, we listen to that baby's heart rate one more time just so we have a solid idea of where that baby was right before the surgery starts. We do skin prep, put her catheter in. She needs to be tilted to her left side. That's what this wedge is on the OR table. So we place like a rolled up blanket under her so that she's tilted to the side. Because remember, baby's perfusion, if mom's flat on her back, baby's not going to get well perfused. So we wedge her. There's going to be a bovie involved if you've seen surgery in order to cauterize bleeding, so patient needs to be grounded with a grounding pad. Clearly we want to have her typed in cross in case we need blood products, and we always give an antibiotic course. We usually give it routinely, and that's to prevent infection. So important for us, and you can go to that page I referenced, but it's important to know what we are responsible for in these situations. So if you're a circulating nurse, you're going to work on counting. Obviously, there's a scrub tech involved as well in this, so it's a very multidisciplinary team approach. The types of incisions we talked about, and remember that our low transverse is what we're aiming for. but what's on the outside for her scar, right? It could look one way on the outside, but you want to know what the actual uterine scar is. So that we find out from the operative report. So what I mean is some providers will do a certain incision on the skin, but then it looks different on her uterus. So the operative report is the only thing that actually tells us that this was truly a low transverse. And I care about that because my patients have more than one child typically, and it's important to know what type of cut was made into their uterus so I could safely labor with them in the future. All right, that's showing you obviously the incisions, and remember that this is showing you externally, and we want to know for sure that that was what was on her uterus. But obviously there's strong advantages to the low transverse in terms of subsequent childbearing. This is again talking about the advantages, low transverse being our primary one that we will see. And then the reason that we're trying to decrease the amount of C-sections that happen is multifaceted for things we've talked about, but also because there's really a real risk. Once we have a scar on somebody's uterus, the next time they get pregnant, they're at risk for their placenta to innervate their uterus deeper than a normal one. So this picture is really worth 1,000 words in showing that. So you have normal here. This is normal placental innervation, right? Normal development. Once somebody's had a scar to their uterus, they're more at risk for a placenta accreta. And that's where you can see this placenta has no longer left that little stratum basalis. It's actually in it. This placenta will not detach when she goes, she has her baby, and then either in a vaginal delivery or a subsequent C-section, the provider cannot just peel. Normally, you can peel the placenta off in a C-section, and it's kind of like peeling the skin off of an orange if you want to get a visual. In this context, you wouldn't be able to do that if there's an accreta. She's at risk for having a postpartum hemorrhage and needing blood transfusion. At its biggest, guys, she loses her uterus if we can't get that placenta to detach. So multiple C-sections put people at risk for developing this placenta accreta. Precreta and increta are even worse. They're worse presentations in the innervation of the placenta, but they're not as common, thankfully. But the accreta is a real risk of multiple C-sections, and she could end up losing her uterus from that. So ending up, if it doesn't separate, she's bleeding too much, the only way to save her is to do a hysterectomy, to remove the uterus. And that could be really affecting if she wasn't done having children. Post-op care, this is where you delve into your med-surg world. The same care you give to any major abdominal surgery patient, so closed vitals, but tack on to what you do for a major abdominal surgery patient, your normal postpartum assessment. So they all have to get mixed together. The other thing that's important here is we add checking the incision. That's an important thing. So making sure there's no oozing, that the incision is clean, dry, and intact. Most of these incisions will be closed with staples, and the patient gets the staples out about 5 to 7, usually 5 days after the surgery. And that's done with their provider, but usually on day 5 we take out those staples. So that's what you'll be seeing when you're assessing the incision. Obviously she's more at risk to form a clot, a thrombus if she's had a C-section because she's in bed. She'll be cathed because she can't get up to ambulate. You'll be managing her pain with Percocet and Motrin, so she'll have more than just Motrin. You can't feed her until she has bowel sounds, so clear liquid until then. And she's gonna need a lot of help with her baby, right? And breastfeeding and positioning and changing and caring for her baby.